could cause the instability of the patient. So in this case here today, it was about psychosocial, right? So you would look at it, hey, you've been stable. What has been unstable? What destabilized you? It was the psychosocial stress, right? The question may and may not give you that, but that's what you have to look into. What you need to do, what the questions will say is, in the last 2 weeks, she was having some inflammation issue in this medication X, Y, and Z was added to the regimen. So your role, if the question had given you that, your role would be to option A, increase your psychotropic medication, or option B, coordinate with a healthcare provider that prescribe the other medications to see when and how the dose is affecting your medication. Collaboration, right? So the two options are possible. Option one most likely would be your action, which would be to increase your psychotropic medication. Okay, if you have a question, please unmute yourself.
Dr. Lopez, I'm sorry.
Hi.
For the first question,
Okay.
if the patient did not have any manic symptoms, we could have picked a lithium, right?
Yes, if the patient was, but then again, yes, you're right. I was going to say, then again, why would you pick lithium? Yes, you're absolutely right. If the patient was stable, had perhaps a history of mania 2 weeks ago, and came to you when no longer manic, and you can say this was indeed mania, then lithium would be the best option. You're absolutely right. Now, there is something that came to mind that it's very, very important. Please write this down for your own knowledge and research. I follow the Canadian Bipolar CPG clinical practice guidelines, and this is what I teach in the psychopharm course because it is the best, in my opinion. This is personal opinion. So it tells you exactly how to deal with a bipolar patient, and it does deal with a bipolar patient how I would deal with them. How? Well, I like to cover them for the mania and for the depressive episodes. And usually what I do is a combination of a mood stabilizer plus a SGA, or second generation antipsychotics. It breaks down beautifully. Like I never seen it before in a CPG. So it's called the Canadian Bipolar CPG, Clinical Practice Guideline, or something along those lines. Google it up, save it, because this is an extremely important resource for you when you pass the board, the PMHNP board certification, and you are ready to practice. And then again, if you're part of the course, you know you have my support. Obviously, even if you're not, you can always email me and I'll help you anyway. So, but priority is for the people that have been in the course, been with us for a while. So, all right. So
Dr.
this is the second
Lopez, I
question.
have a question. 1 second, Dr.
Please go
Lopez.
ahead.
Tell them, when the question is coming, people are talking behind, so we cannot get concentration.
Yes. So kindly mute yourself unless if you have a question, and I'll remind you guys throughout because I know mute and unmuting your microphones can be a little bit of a challenge. But let's get to the next question. Most of you guys got this question correct about the psychosocial. Just adding on for the board here. If you have a stable patient, this is important. This is likely to be in your board, I promise, in some way, somehow. If you have a patient that's stable, and that can be for any medication, do not destabilize your patient. Once you got your patient stable on any medication, your first action is to do what? Let's say this is a antipsychotic, and you have stabilized your patient. Your patient has gained weight and is complaining about weight gain. What is the number one thing that you're going to recommend as your first recommendation is what?
Lifestyle changes.
Diet.
Dietitian.
Beautiful. Beautiful. Right? So exercise, two, lifestyle changes. They will not It could say exercise, but lifestyle changes, it encompasses all that, right? So umbrella answer, lifestyle changes, which is dietitian, diet, exercise, mood regulations through sleep, and things like that. That will be your first action. Then after that, if that doesn't become successful, I doubt the question would go in more details, then you can consider change of medication. Super important, write that down, okay? Because you're likely to get a question like that. Please do not destabilize your patient. You worked so hard for this. You got the patient where the patient needs to be. Do not change the medication at this point. Lifestyle change is the best option. Great job. Thank you. You have 20 seconds. Please mute yourself if your microphone is on. Oh, okay. Perfect. Right. So yesterday somebody asked a great question. The difference between addiction versus dependency, right? The addiction is you are doing anything, not you, the patient is doing anything that needs to get that medication or the drug, meaning driving drunk, spending all the money, destroying homes, family, and so forth, as long as they get what they need. Dependency is referred to the body depending of the medication. I also explained that yesterday that easy topics will come with hard questions. This is the easy topic, and this is about tolerance. Tolerance is needing more of the same substance in order to achieve the same results, right? So pay attention on our course for easy topic. You'll be like, oh, I got this. I promise you it will come with a hard question. Make sure that you just don't get it, but you fully understand. You love the learning journey, because passing the board is the first step, but nowhere near the last step, right? All right, we covered this in our course yesterday. Hopefully everyone gets it correctly, unless if you did not have the time to attend our meeting yesterday. Beautiful. Well done. So since we all got this one correctly, good job, Sammy PCW, Katie and Jerry C. So y'all taking the lead here. So now let's talk about scales for ADHD. Can someone, one person, you can mute your mic and tell me the two scales that we covered yesterday? How would
We
you,
covered the
what scale would you use?
Van de Beek.
Okay,
Van de
which
Beek.
one?
The MCHAT.
MCHAT is for
MCHAT? What's
total-
MCHAT for?
No.
Okay,
O'Connor.
so
ADHD.
O'Connor and Vanderbilt. Which one
Van
is
de
the
Beek.
which one is in a public domain? It means free.
Vanderbilt. Vanderbilt.
Okay, so we also cover a very important topic yesterday, what about scales in general. I mentioned that you need to know the scale by the acronym like MCHAT, because on the test they will not put what MCHAT is, right? They'll put only the acronym. So if you don't know what it is by the acronym, you are likely to miss an easy question. Okay, so please take the time to memorize, understand the acronyms for each and all scales that we cover. We don't want you to miss easy questions, especially when you know the answer. Perfect. So I forgot to introduce myself. If you are new here today, my name is Dr. Lopez, and I teach how to pass the board. So you might be asking, why do I have one eye closed and one open? Well, basically, I had the retina detachment. It's not that I don't want to look at the question, but the brightness of the screen kind of hurt my eyes. So I'll keep one of my eye closed while I speak to y'all. Okay. So this one was pretty easy. It was about ADHD. Uh, uh, Condition, right? So most of you guys got it correctly. I think the explanation of the question does the good job here. So, oh yes. So GAD, right? I explained it also yesterday that the questions will never ever give you a full picture of the condition. Meaning, if the question asks about major depressive disorder, it will not give you 5 symptoms over 2 weeks, other than medical condition and so on. That would be required for you to practice and do the diagnosis correctly. What the question will say is most likely diagnosed. So pay attention to that. If you are a very concrete thinker, like I most of the time I try to be, will lead you to the incorrect diagnosis. What I wanted to pay attention to you at this time is the GAD, or generalized anxiety disorder. For that one specifically is the exception. That one, it needs to say 6 months. Okay, so pay attention. That's high yield, especially about GAD. Okay, so perfect. Most of you guys got it correctly. Please mute yourself if your mic is on. Attention deficit or hyperactive disorder, ADHD, right? Now, why wouldn't this be a oppositional defiance disorder, ODD? when you hear about oppositional defiant disorder, ODD, I want you to think of a child that's not following the rules, right? And in order to not follow the rules, you need someone to write the rules, right? They can be the teacher, the parent, and they have a problem in following the rules by a leader or the leadership of the household, or the school, or so forth, and they'll act up. But this is not as much as conduct disorder. And remember what we said about personality disorders. You can rule out some of the answers or rule in by looking at the age. For for personality disorders in general, not 100% accurate, but in general, it needs to be 18 years old, has to be an adult, right? In order to say a personality disorder, generally speaking, for the test purpose here, okay? Not 100% accurate, but good for the test. All right, so we are getting very close. Every time we're improving a little bit more on ADHD diagnosis, and the team here is ADHD, right? So lots of questions on the same subject. So if you look at the prefrontal cortex, there is a dysfunction there, right? Now, what else? What other parts of the brains are involved with ADHD, right? So we have the reticular reactivating system, right? That involves with sleep. The basal ganglions are also involved. We cover each one of those parts yesterday, so pay attention. These are high yield information that you need to know. Okay. Perfect. We're getting better and better and better each time. So as far as stimulants, you need to know the age that the medications can be applied to. Methylphenidate 3 and plus years old, and amphetamines, I'm sorry, amphetamine 3 and plus, and methylphenidate 6 and plus, right? So just to summarize it, you can just memorize uh, the age and the groups of the medications. There are other medications that are not stimulants that you need to know as well. Okay? And remember, I don't care what case the question presents, I don't care how good the stimulant has done for the child. If the child develops a tic, a tic, motor tic or vocal tic, you stop the medication and you prescribe a non-stimulant option.
Hey, Doc.
I can't stop, but please tell me the question once it's done, okay? Okay. This is going to be an invalid question, okay? Two options are possible.
Exactly.
Two options are there.
Mm-hmm. Okay, perfect. Before we answer this question, someone had the questions on the previous slide. Can you please ask your question?
Yeah, I was asking, I'm new here. How do you participate? Like, I kind of know the answers, but I don't know how to kind of
Yes.
do I use my phone or something? I don't know.
Yes. So you look at the answer through the Google screen that you logged in, and you go to
Uh,
kahoot.it, and then you write down. You have to write down the PIN code 609-4200. Pick a nickname,
Okay.
and then you should be logged in. So write it down the PIN code 609-4200. Okay.
Okay. Hold on a minute.
All right. Okay. While you do that, I'm going to go over this question here. So why would this question be an invalid question, right? So the point is that you stop the medication if you prescribe a stimulant and the person develop a vocal tic, a blinking, a modem tic, what have you. But really, you could do accommodate too. It's a non-stimulant, right? But it may not be the first choice when the tic is present due to alternative option. Not really a very good answer, right? Not really. So you could do accommodate, just that the tests really love a guanfacine or, or other options. But if the options only accommodate, I want you to pick that. Okay. So it's not necessarily a true answer, but perhaps guanfacine would be the best option specifically for the tic disorder. Okay. But I doubt that the question will put these two answers as possible options for you. So you safe. If you even you pick actomycin or Strattera, it would be a most likely correct answer. Okay. Same case as the previous question here, right? All right. So same thing as the previous question. Incorrect. If you pick atomoxetine, or Strattera, or guanfacine, or clonidine. These are all possible answers. But what would be incorrect for sure would be Vyvanse and methylphenidate. Let's talk about Vyvanse for a second. Why Vyvanse would be a good option for those that are at risk for substance abuse? Let's say I have a patient that I really think the patient has ADHD, and I had done some psychoanalytics, and the patient has a history of drug usage, but I really think he would benefit from a stimulant. I would pick Vyvanse. Why would I do that? Okay. So Vyvanse is a special drug, right? A stimulant that helps. Well, let's say that not you, but let's say that people can crush and do things to a medication and use it in a inappropriate way. Well, Vyvanse has this property that only gives, or supposedly, or in theory, only gives you the high or rush if it's digested rather than used in a different manner. So if you have a patient that you are considering a stimulant, but you are not so sure due to previous history of drug abuse, Vyvanse could be a good option. Okay. So as I mentioned, guanfacine or clonidines are a great option for a someone that develops a tics, or a someone that you want to give it a non-stimulant, especially for children. Now, I have used a combination that I think is very interesting. I have used clonidine and the stimulant, or guanfacine and the stimulant. Why would I do that? Well, let's say I have someone that has high blood pressure, right? So I'm still, I'm still working with the ADHD diagnosis, but I am augmenting with a alpha 2 adrenergic agonist, which has been used for both ADHD, but also helps with high blood pressure. So that's why knowing your pharmacological medication, it really helps you to bring the best of you to the table and help those in needs, right? I don't do that very often. I always prefer to do one medication, give it the highest dose possible over time before I add another option or a third option.
But
Okay.
but Dr. Lopez, do we give Vanvas to children?
Well, we could, right? We could, preferably not, but we could. Usually, this is a more expensive medication. Usually, I tried that. If I'm considering Vyvanse, is only because of the potential of drug abuse, and in that case, it would be an adult, right? Now, also, just because Vyvanse may have a is more expensive, right? But think of it as, why would you pick Vyvanse rather than Ritalin or Adderall? What's your rationale, right? So my rationale, I always take in account cost, potency, the patient preference, and my clinical judgment in order to make any decision, right? So Vyvanse to me is a great drug, more expensive, not for everyone. In fact, my pharmacy requires prior to authorizations, that make me say, hey, I have prescribed two other options. They have not been successful in order for me to prescribe, because there is a cost involved. And we have to keep that in mind as well, socioeconomics. Right? But usually I would not prescribe that for children or adolescents. All right. So if you look at the slurred speech and slow reaction time, you would be most likely talking about alcohol intoxication most of the time, right? Uh, so I queued in incorrectly. So I am super sorry about this one here. The right answer is agitation, restless, and increased level of energy, right?
Oh, thank you, God.
Specifically, yeah, no, I'm so sorry. I have a team that does this for me, and they don't necessarily have always the go back to it and recheck. So that would be the correct answer. Now, insomnia, right, would be a good one to keep in mind as well. Okay?
I was saying overdose. I wanted to say because they said wrong. Agitation,
Yes,
restlessness, and increased energy is one of the signs of stimulant overdose because it's stimulant. So
yes,
I'm surprised when he says
absolutely, yes.
slot speech.
Yeah, especially insomnia, right, as well. But it doesn't mean that they are abusing. These are just signs, right?
Mm.
Eddie, your mic is live.
Oh, okay. I'm sorry.
All right, perfect. So just overall info for you guys. If you're dealing with children and even adolescent, right? If I ask for a psychotherapy of choice, always be a watch out for parent and teaching skills, right? Because think about it. If you are just recommending a child for a therapy and you don't have parents involved, most likely that option would be weaker than having the parents involved. When it comes to ADHD, when it comes to ODD, when it comes to any of the children and adolescent conditions that we described yesterday during our course, parents teaching, it's super high yield. Okay, parents and patient teaching or therapy, you got to have the buy-in of the parents in order to get a successful uh, uh, getting the patient back on track, right? Mm. This one's a hard one, right? It's gonna be a very hard one. All right. So very hard one. So I do apologize. Behavior therapy focused on symptom reduction. It is appropriate, but it doesn't necessarily trump the psychoeducation for the parents and the child, right? Not that is an incorrect answer. It's just not the best answer for this choice. If the psychoeducation for me and her and her parents were not available, uh the other option would be the best next option, right? So just like in nursing school, the questions always give you a right answer and a somewhat correct answer, just not the best answer choice. Okay, perfect. So borderline personality disorder, right? Would be the best option here. Let's take a look on the rationale. So when we speak about borderline personality disorder or any other personality disorder, we really want to look at the age when possible to possibly discern of possible answers, right? And it's most likely the diagnosis here is because of Mark's clinical presentation. Okay. Do not confuse borderline personality disorder with bipolar. Okay. Oftentimes patients confuse that. So you have to ask more questions in order to get the right answer. Lower the volume. All right. So perfect. Well done, everyone. 100%. You also need to know who created DBT, right? That's high yield. There are a few names that I put in our course that you need to know. Not a lot. Not all therapies there is a name attached to it, but DBT, Marshall Lineham, super important. Mm. All right. So let's take a look here on this because not necessarily the best answer. So
Yeah, I'm saying not the best answer.
sometimes
No,
we
why
can
is it
use
not
right?
the
I
best
will
answer? Why is it not the best
no, we'll go back
answer?
a little bit.
Because this patient is impulsive.
Okay. All right. So when it comes to borderline, if it doesn't give you a straight up symptoms of impulsivity or few other the symptoms, so when it comes to borderline, always consider a mood stabilizer. The two mood stabilizers that we consider sometimes, depending if they give you the symptoms, it could be lithium or Depakote. But generally speaking, right, an SSRI would be the best option. So it's the first option. I wouldn't say the best option. Okay. So the question here didn't give you a lot of symptoms, was more of a vague. And if you just want to kind of initiate uh, a pharmacological treatment specifically aiming at comorbid disease or major depressive disorders, SSRI would be the best option. Now, to be
Yep.
fair,
But
to be fair,
presents with some
right,
mood swings.
right.
But
So as long
impulsivity
as
is there.
impulsivity, but it doesn't tell you.
It doesn't tell, but he said bipolar and what do they call it?
Not bipolar, right? Not
No,
bipolar.
I'm talking about
Borderline.
borderline. Borderline
Yeah.
is impulsive. They have these suicidal thoughts. So I think SSRI is the best answer to it, especially suicidal thoughts.
Yeah, probably the best answer, but not the only answer. That's what I'm
Yeah,
trying to
it's
get
not the
to.
only answer,
So,
but the
so if you right, so if you are trying to, there is a part of the course. There is a part of the course that I break it down exactly when to prescribe an SSRI, when to prescribe a lithium, or when to prescribe Depakote. Okay, so we'll go back more to this subject, and we'll pull the slide, maybe probably during the classes, and then we specifically highlight when. Now, if the symptoms are vague, would you initiate a mood stabilizer versus an SSRI? SSRI? Probably the best answer, SSRI. However, I think if the question was to ask you this in the test, they will give you a little bit more to go by. So you're not wrong for picking a mood stabilizer either. Just probably the mild, least problematic answer for the patient. Um, start with the low kind of the lowest possible drug that can probably do the most benefit. If that fails, bring the big guns. In that case, it would be a mood stabilizer. Right? Okay. Remember too that in Kahoot, it does not allow me to put a complete answer. So most of the time, I can just have few characters in order to put in the answer. So I have to be very, very creative. On the test, they'll give you a more complete answer, not question. Okay, perfect. So I think we got that covered. All right, so we have a lot of people here taking the lead. Here's the rationale. Remember, for the test, specifically for major depressive disorder, they will not give you all the symptoms and the time frame. It will ask the most likely diagnosis. Okay? Also, in relation to obsessive compulsive disorder, we have obsession compulsive disorder and we have obsession compulsive personality disorder, which is different. When it comes to OCD specifically, remember, a tic can be one of the relieving modems activities that they may do in order to relieve anxiety. Okay, so don't jump. The point here is don't jump to Tourette's or modem tic without finding more information about the question. All right, so I can see social anxiety disorder versus avoidance personality disorder, right? But this is avoidance personality disorder. So let's take a look here in a rationale. When you look at the avoided personality disorder, right? They basically, hey, they don't want to get in a conflict. They rather just let you have it rather than getting in a conflict or even socializing in general, right? Which is a bit different than when we speak of a social anxiety disorder. So social anxiety disorder is that they don't want to be around others because they feel that generally speaking, right? That people they're afraid of making a mistake and being ridiculed, perhaps in public speech or in social settings, right? They do share a lot of commonalities, but the best answer here would be avoidance personality disorder, right? Which would be a cluster. What cluster would that be? A, B, or C?
Cl- cl-
See,
C.
C.
C, cluster C's, right?
Cluster,
So in
cluster C.
practice, if you don't want to call it right away because it's your second or third interview or even first, you just put a tendency to display cluster C personality. And over time, as you gain more information, you can change the diagnosis. Remember, the diagnosis, specifically those with personality disorder, can be detrimental to someone's future job outlooks, right? I give an example. If you call someone, you call someone they've antisocial personality disorder, that might very well exclude the person of the possibility of getting a job, even if they are well qualified for it, right? So just be careful. I'm not telling you to not call it. I'm just saying be careful. Your actions has results negatively or positively on your patient's life.
I have a question.
Someone's mic, we have to wait. I'm so sorry, I
Okay,
was
all
fast.
right, okay.
All right. So before we proceed on this question, someone had the question. Please ask your question.
In terms of the clusters, do we need to know what's the different personality disorders in each for the boards? For the boards?
Yeah. I, I
Oh, you're
wouldn't
lagging.
think you need to know. What you need to know is a schizotypal, schizoid,
Okay, it's better
sorry,
now.
down paranoid, right? Can you hear me? Can you hear me? Hello? Okay. So I wouldn't say you need to know all of them in detail, but I would take a look uh, on them and be able to pinpoint few things or characteristics of each one of them. For example, paranoid personality disorder, schizoid, schizotype. Then let's move on to cluster B, borderline personality disorder, antisocial personality disorder, narcissistic. Let's go to cluster C, your avoidant personality disorder, and the least common, let's say, obsessive personality disorder. So there are more, but these are the main ones, right? We can also put a histrionic on cluster B there. So because it doesn't take much of a time and is also good for practice. So I would be aware of them, but I don't think you absolutely have to. But again, it takes such a small effort to kind of understand them and kind of like, okay, I can tell you a few things about them. So I think it's worth your time of going over them and kind of understanding, because you don't need to necessarily understand and be able to speak about that. But if you hear those traits, you should be able to pinpoint what the question is asking you for,
And Dr.
right?
Lopez, let me come in. I want you to, if you want to know them, paraphrasingly know them, I want you to watch Dirty Medicine. Dirty Medicine. That's where I really, not that Dr. Lopez is not teaching, but I got my the real explanation from Dirty Medicine. If you just go into
Yeah. So
Dirty Medicine, it will show you
Okay.
YouTube. It will
yeah.
really
So
make you to understand. It will give you pictures of the kind of people, a narcissistic person, a schizophrenic person. It will give you. So it's about 5 minutes.
Okay.
YouTube. Yeah, Dirty
yeah.
Medicine.
So please go ahead and share on our Google chat box so others can learn from it. So yeah, I really think that it's never about me. It's all about you. So if you have something, if you learn something from somebody and you have it's beneficial, hey, I can learn from everyone. I learn from each one of you guys every single time. So we're about the community. We're about to make us stronger as a community and obviously help you pass the board. So if you have good resources, as long as they're appropriate and they're not harmful in some ways, please share. It's never a problem. Okay. All right. So schizoid personality disorder. So this is a good one, and it came actually in a good time, right? Let's take a look here on schizoid, right? Can someone define or tell me what do you think a schizoid personality disorder is, or some traits of it?
Okay, let me come. A schizoid personality disorder is a cluster A personality disorder. The people, they
Mm-hmm.
like solitary life,
Yes.
self-isolated. They like working in maybe night shifts. They hardly make friends. They are
Yes.
on their own. It's not as if they are destructive. No, they are not destructive, but they just want to be on their own.
Mm-hmm.
That's the kind of person they are.
And how is it different than schizotypal?
Schizotypal has some kind of psychotic symptoms that if you don't control it, it might move to bizarre symptoms that if you don't control it, might move to schizophrenia.
Okay.
Yeah,
So
but
I
in what's that? In schizotypal, there's no hallucinations or delusions.
right. So the key here is bizarre.
Mm.
And I don't necessarily think it would move to schizophrenia, but what we see is it can be a predominal phase, meaning that they in general not schizotypal, but the patients that are before they move to a schizophrenic full blown, they may present a predominal phase, which means they may be disorganized, they may have very weird patterns, and some people might call it bizarre. So the schizotypal is the one that I say, hey, if you see a guy that's putting a tin foil over his head and wearing that to work, It's not necessarily a schizophrenic. It's just very bizarre, right? But they don't necessarily, it's a personality disorder, not a disorder in itself. It's a personality. Okay. But thank you. I think your example was very accurate and very informative. I appreciate you sharing the thoughts with us. All right, so this one actually fits the bill pretty well. If you have your mic on, kindly mute it. Alex presents with a magical thinking, unusual perceptual experience, having beliefs in special power and supernatural phenomena. You can see how this is different than the schizoid, right? So not necessarily enough to call it schizophrenia or brief psychotic disorder, but it's just odd, eccentric, but nothing wrong with the person. We can't just say, you know,
John, what'd you say?
I'm going to give you, I'm not going to give, I'm going to give you a
It's gonna be like
antipsychotic.
20 minutes. This is over though. It's gonna
Someone
be like
has
20
a hot
minutes. This
mic
is
there.
over.
Hello, someone has a hot mic there.
You win. Oh,
So it's not enough. It's not
Cheryl,
enough to call it.
Cheryl, your mic is hot.
It's not enough to call it a schizophrenia. We're not going to give a antipsychotic to this person. It's just their own personality, right? They're not harmful. They're not harming themselves or harmful to others. So they just like to be alone. They have this magical thinking. I can look at this license plate and I think this is going to be the lottery. But if you give antipsychotic, it's not going to fix that. That is their personality. It may diminish, but it won't fix it, right? And it's not wanted to do it. It's not the best. It's not for the best interest of the patient either, right? So we always have to look at things in a different perspective, because we can say, oh, okay, let's give you antipsychotics, but it comes with a cost, right? First generation, what's the cost? EPS. Second generation, what is the cost? Metabolic syndrome, right? And if you are in the course, you know very well what's the difference between the first generation, second generation, and how to classify metabolic syndrome in detail, because that's important. Okay, so did I? I'm not sure what happened here on this question. So I can't go back either to take a look at it more closely. But why was this in generalized anxiety disorder?
This looked like a repeat of the one before.
I guess. But I'm wondering why most of you guys picked generalized anxiety disorder.
I think you're looking at a different screen because it's 0 for generalized anxiety disorder.
No, it's schizophrenia. They picked 6. It's not generalized anxiety disorder. It's schizophrenia.
Oh, okay, yes. I'm sorry.
6.
Yeah, no, you guys are right. It's just my eyes are blanking out on me. For some reason, I was looking at the colors, the schizotype personality disorder, and I was associating with the generalized anxiety disorder. Yes, perfect. Thank you. Yeah. Good job, everyone. So also wondering on this question, how many people would pick schizophrenia rather than schizotype, right? I think this was a repeat of the last question for sure. And still we got it incorrect. So if you want to, if your mic is hot, please mute yourself kindly. If you want,
your mic is on.
if you want, you don't have to. I'll give 5 seconds. Anyone who would like to give me a rationale for picking schizophrenia? You don't have to, okay? I just want to clarify a few things if it's helpful to you. You don't want to, that's fine. And that's totally okay. It's not meant to, it's meant for clarification only. If you unmute yourself, I cannot see your screen, but you can unmute yourself if you have a question. Okay. So what are the criteria, generally speaking, we don't have to go by the book, for schizophrenia? How long does it need to be to have those symptoms?
Over 6 months.
2
Over 6
symptoms
months. Okay.
or 6 months.
Yeah. Okay. Generally speaking, it has to have well, more than 2, but has to have the disorganized speech or hallucination or persecution. Some of those more hardcore symptoms, right? So in this case, I don't think the test will give you in real life. You need that for 6 months, but because if it's less than 6 months, it could be a what? How would we? Let's say the patient presents with schizophrenia symptoms, but it's less than 6 months. What would be the possible diagnosis?
Schizophreniform.
Yeah.
Schizophreniform.
Okay, all right. So let's stop here. Schizoform, right? So what is that? What's the time limit?
Less than 6 months.
But okay, but there is something else that less than 6 months. That's day 0 to 30. What we call that?
Disorder.
Say it again.
Brief psychotic.
Yeah.
Psychotic disorder.
Okay, so 0 to 30. Let's call it. I'm generalizing here so you can conceptualize. Okay, 0 to 30 we call brief. Day 31, right, to less than 6 months, what we're gonna call less than 6 months, what are we gonna call
Schizophreniform.
Schizophreniform.
schizophreniform? Okay, perfect. Okay, and then after 6 months, we call it schizophrenia, right? This is for
Schizophrenia,
practice, but it's also good to understand for the board, right? Now, this is a personality disorder, schizotypal. So it's like some characteristics are the centric, but not hallucination, not hardcore symptoms of schizophrenia. Okay. So it's only meant to teach, not to, if you pick schizophrenia, it's totally okay, as long as you know a little bit more of the difference. Okay. Pervasive distrust and suspicions of others. What patient we would be most likely referring to? All right. So yes, absolutely. Cluster A, personality disorder, paranoid, right? So here we have it. Paranoid personality disorder. Please take a look at the rationale. You know, the question said reverse um, suspicions of others, right? So it's like, okay, the government is tapping on my phone or looking at my house from a satellite. And not just say those patterns couldn't really show up in schizophrenia, which often they do. I can never forget this. It's been over 15 years, and I asked the patient with schizophrenia where she lives. I don't know why I asked that question. I guess I was trying to ask a conversation or strike a conversation. She's like, "Why do you care? Are you gonna follow me? Are you looking at me? Why you wanna know exactly where I live?" And that was only meant to say, "What city do you live?" Right? So they may have those paranoid thoughts. Maybe the question wasn't the best either, but ever since that moment, I was like, okay, I have to be careful what I ask because my intentions are not important. What's important is how the patient receives the question, right? So learning from experience, it's important. All right, so perfect. So during my last year of DMP, I went to a hospital in North Carolina, and then I shared an apartment with I would say a friend, right? He's a high rank. He also his family was in Charlotte, and then he just came to North Carolina, a specific city, for 5 days and spent the rest of the weekend with the family. So I left my family in North Carolina, and then he is a high rank person with substantial amount of power and money. Let's put it this way, and we shared an apartment. So just for the clinical period that I was there for 1 year, I didn't want to move my family. So I opened a DSM-5, and after getting to know him well, and we became super friends, and I said, "Hey, can you read this for me?" And it was obsessive compulsive personality disorder. And he read. He's like, "Are you pulling my leg?" And I said, "No." And I said, "I'm just want you to read it." He's like, "This is me, totally me, right?" So they are over preoccupied with perfection to the point that they never deliver the project. They are over preoccupied with, well, he was with saving cents when he could have bought buy whatever he was not buying and saving him time and money. The narrow focus, it will become destructive in a sense that he was hoarding things that he didn't need to in his house, beautiful house, big house, was causing problem within his marriage. So I started doing some therapy with him. I'm like, hey, do we really need to be so perfect or stingy to the point where you're saving a penny here, but it's costing you few $100s for not doing X, Y, and Z, right? So it's only a problem specifically with personality when becomes a less than ideal pattern in society for the patient or the family, right? So he's like, "Well, are you pulling my leg?" So that is the characteristics of obsessive personality disorder, not OCD. Very different, very very different. I don't even know why they decided to call it the name in a similar way, right?
No,
But
it's
that
because
is
of the the perfectionists, they must check
Yes.
their job 2 times to make sure that it is perfect. The I's are dotted, T's are dotted, and then the other one
Right.
is that they'll keep washing hands, that kind of restlessness, that kind of perfection, doing things. That's why maybe they link the names. But one is a personality,
Absolutely, yeah.
one is dystonic, and the other one is dysocial.
Okay, I love it. Yes, actually, a very good way of explaining it. But is a life perfect, right? Sometimes we can take a 90 on the test and walk away and be happy and have time to spend time with the family and go on and live a beautiful life rather than the person that's trying to get 100 every time. And it's causing money issues, family issues, friends issues, all that, right? So when obsessive personality disorder, it becomes so obsessive with getting their goals or whatever might be that they neglect everything else and end up costing 10 times, 20 times as much, right? All right, we have 20 seconds left. It says submissive and clinging behavior, fears of separations from loved ones. Okay, so perfect, right? Don't confuse this with borderline personality disorder, right? They have the need to be close to others in relationships, and when the relationship breaks, they go usually bizarre and labile attitudes, right? Or mood sometimes. Hot mic, someone. All right, so this is a very clear example of autism spectrum disorder, right? We cover in detail this yesterday, so hopefully all of you guys get it. But when we think about autism spectrum disorder, think of a severe lack of communications and social interactions, right, with others. Often they neglect or they don't look when called by their names, right? Especially children. Unless if it's a familiar face and they're like, oh, mommy, okay. All right, 5 seconds left. Much like the previous question, if not the same, very similar. So that is autism spectrum disorder. Okay, same thing, just different patient, different age, right? So one thing that you guys have to be aware of is that they lack of imaginary friends, right? Imaginary friends is healthy, depending of the age, is normal, depending of the age. But this condition usually lacks of imaginary friend. What condition would that be? What diagnosis would that be? And if they have the habits of lining up toys, it might be 50 toys. They know exactly which one you messed with, right? So again, the same diagnosis. Sometimes I will repeat questions in a slightly different way, maybe to help you really cue in and not
Yeah,
forget.
yeah, but Dr. Lopez, sometimes this your they have already started.
Oh, yeah,
Don't
sorry.
worry.
You guys are super fast. All right, so that is applied behavior analysis, or ABA. Let's take a look here on the rationale, right? So applied behavior analysis, ABA therapy. Sorry, I'm kind of 1 second here. So it's one that we can use with autism spectrum disorder. It's highly effective and is a non-pharmacological intervention for children with ASD. Okay, so keep that one in your books and please make sure you know of this one. CBT, it can be used, but not as high yield or effective for those with the autism spectrum disorder, right? Remember that oftentimes autism spectrum disorder, it often comes with other conditions, right? In this question here, ADHD. So the core of the question, why is ADHD effective? Okay, so here we have it. It modulates in the reuptake of dopamine, right? This is why it is effective. Now, I think this question also, or the answer, touched on the broken mirror neurons. What is that? Actually, 1 second. We'll be back. Just let's see who's the winner for today. WG. Then we have second place, Uri. And the winner of today's event is Manu. All right. You guys all did well, Betty and Becca. Everyone else, good job. You know, I always share this story of somebody, not always, but last week we had someone that passed the board, and she said a few things. And she said, hey, you know, the first time I played Kahoot, I was number 26, and then I was number 25, and I kept on playing, and her score was always increasing. So although it's not a absolutely must, but the more you practice, the better you get. And it really showcases your dedication, and it showcases where you are on your journey to become a psychiatric mental health nurse practitioner. So whether you were the winner of today's event, which is super cool, or you didn't this time, be aware that most of the weeks, except holidays, will be here. The same link. I don't even change the link to make sure that everyone is able to participate. Show up 15 minutes before, 10 minutes before, get your account set up so we can play the good Kahoot game and help you pass the board. With that being said, it concludes today's event. I'm going to stay behind to help those that are part of the class kind of get any questions answered and kind of get you, you know, a little bit better towards passing the board. Every single day, every single thing that you do, every single day counts towards the final results. If you feel tired, if you feel you don't want to do it, if you feel it's late night, do it anyway. Set a time, 2 hours a day. There is no magic bullet. I think we'll try as much as possible to get you what you need in one place with full of resources, but your determination, it is the final outcome, right? So we can give you the best resources, but if you're not willing to put the time, then it becomes difficult, right? Which I know is not your case, but do it anyways. You can do this for 30 days, for 40 days, 60 days, 90 days, how long it takes. We'll be here to support you and your lifestyle, however you like to learn. We'll be here and help you pass the board. So as that being said, I'm gonna stop this recording, and then I'll stay behind, and we can cover anything, any questions that you have or any concerns that you may have. 1 second, let me stop this recording. All right.